I'm going to discuss two white-dot syndromes in this lecture. First of all, punctate choroidopathy, and afterwards, multifocal choroiditis and panuveitis. Starting with PIC. PIC typically affects young myopic women. Both eyes are frequently sequentially involved. It has similarities with MCP, but involvement predominantly involves the macula. It is sometimes categorized with multifocal choroiditis and panuveitis as pseudo presumed ocular histoplasmosis syndrome, which we have discussed, and I will link it by the end of this lecture. Patients usually present with symptoms of blurring, floaters, and photopsia. Anterior uveitis and vitritis are usually absent or very mild. Fundus examination shows several small yellow-white macular spots with fuzzy borders at the level of inner choroidal and retina, sometimes with an overlying serous sensory retinal detachment. These macular spots are shown in the figure here, and they are very prominent in the macular area. Just above the fovea here, there is suspicion of CNV, but in the same eye, in the same patient, after 2 weeks, this choroidal neovascularization develops. Now, these macular spots evolve into sharply demarcated atrophic scars with little pigmentation, similar to the histospots of presumed ocular histoplasmosis syndrome. Prognosis is poor, as central vision may be compromised by a lesion at the fovea or commonly by CNV in up to 40% of the cases. Coming towards investigation, one most important investigation here is fluorescein angiography, which shows early hyperfluorescence and late staining of lesions and demonstrates choroidal neovascularization. In the first picture here, in the venous phase, the arterial phase, we see these hyperfluorescent lesions with hypofluorescent borders, and we see the lacy pattern of hyperfluorescence around the foveal area. However, in the late phase, this hyperfluorescence, it becomes intense, and the choroidal neovascularization, it becomes very prominent. So it is a very important investigation. Treatment is with anti-VEGF medication for choroidal neovascularization in the macular region. Steroids and systemic immunosuppressive therapy can be helpful in the management of recurrent CNV. Next is multifocal choroiditis and panuveitis. Multifocal choroiditis and panuveitis is an uncommon, usually bilateral but asymmetrical, chronic recurrent disease that typically affects young and middle-aged adult females. Severity and prognosis are very variable, along with punctate inner choroidopathy. It is sometimes termed pseudo presumed ocular histoplasmosis syndrome. Now, patients present with symptoms of blurring, floaters, and photopsia. On examination, 50% of patients have anterior uveitis, Also, patients present vitritis is noticed. And for this examination, there are multiple discrete ovoid yellowish gray lesions, 50 to 350 microns in diameter at the posterior pole or periphery, sometimes with linear clusters or streaks. Inactive lesions have sharply defined margins, and pigmented borders resemble presumed ocular histoplasmosis. As is seen in the picture here, these are inactive lesions which resemble the histospots. Now, peripapillary atrophy may be seen. The course is prolonged with the development of new lesions and recurrent inflammatory episodes. Choroidal neovascularization occurs in 25 to 35%. CMO and subretinal fibrosis resembling subretinal fibrosis and uveitic syndrome can develop. Optic disc edema and blind spot enlargement may be present. Upon investigations, visual fields may show large defects not corresponding with examination findings. Fluorescent angiography is very important. It shows early hypofluorescence and late hyperfluorescence. Old inactive lesions show window defect. If a new vascular membrane develops in the macular region, hyperfluorescence is seen due to leakage. As it is seen here, the hypofluorescent and hyperfluorescent areas, it's a hyperfluorescent area and there are multiple hyperfluorescent areas in the early phase. But later on, you can see the CNV here, which is previously there is this lacy pattern here. Later on, it is hyperfluorescent. So this is a very important investigation here. Now, indocyanine green angiography shows hypofluorescent acute lesions, which may not be clinically apparent, and all lesions remain hypofluorescent throughout. ERG remains normal until there is advanced retinal atrophy. Afterwards, there is treatment, systemic and local steroids. Steroid-resistant patients require immunosuppressive therapy. CNV is treated with steroids and anti-VEGF agents. So we are now concluding the topics of punctate inner choroidopathy and multifocal choroiditis and panuveitis in this lecture. Thank you.